Assalamu alaikum. The topic of today's lecture is anemias of diminished erythropoiesis. These are our learning objectives. Now, anemia is defined as the reduction of total circulating red cell mass below the normal limits, or the reduction in content of hemoglobin below the physiological limit. Anemias of diminished erythropoiesis is a heterogeneous group of anemias that occur because of inadequate or deficient production of red cells. These anemias are classified according to pathophysiology. Most common cause is nutritional deficiency. So, in nutritional deficiencies, there may be deficiency of vitamin B12, folic acid, and iron. This can lead to decrease in red cell production. Other causes include inherited genetic defects like stem cell depletion or erythroblast maturation defects. Erythropoietin deficiency is another cause which may occur in cases of renal failure or anemia of chronic disease. Immune mediated injury of progenitors can occur in cases of aplastic anemia and pure red cell aplasia. Inflammation mediated iron sequestration can occur in cases of anemia of chronic disease. Primary hematopoietic tumors like acute leukemia, myelodysplasia, and myeloproliferative disorders can also lead to decrease in red cell production. Space occupying marrow lesions like metastatic tumors and granulomatous diseases can also reduce red cell production. Infections, especially viral infections like parvovirus B19, they can also reduce the production of RBCs. And then there are unknown mechanisms which occur in endocrine disorders and liver disease and result in deficient red cell production. Now, there are various classifications of anemia. The classification that we'll be discussing here is classification based on the size of RBCs. And based on the size of RBCs, we classify anemia into microcytic, normocytic, and macrocytic anemia. Macrocytic anemia can further be divided into megaloblastic and non-megaloblastic anemia. Megaloblastic anemia is because of nutritional deficiency of vitamin B12 or of folic acid. Non-megaloblastic anemia is because of alcohol, reticulocytosis, for example, like in hemolysis. It can be because of liver disease or hypothyroidism. Now, here we'll be discussing megaloblastic anemia. Megaloblastic anemia is anemia that results from impairment of DNA synthesis leading to ineffective hematopoiesis, and this results in distinctive changes in the morphology of RBCs, which includes abnormally large erythroid precursors as well as mature red cells in the peripheral circulation. So, because of impaired DNA synthesis, the RBC production it is defective, and because of that, the RBCs they are larger in size, both the precursors as well as the mature cells. The causes of megaloblastic anemia include vitamin B12 deficiency, which may be due to pernicious anemia or other causes, and folic acid deficiency. On morphology, on peripheral film, the RBCs they are macrocytic, large in size. The MCV is increased more than 100 femtoliters. RBCs may be round or oval in shape. Teardrop and various other deformed RBCs may also be seen on peripheral film. Another feature is hypersegmented neutrophil. This is again because of ineffective formation of the blood cells. Normally, a neutrophil it has around 3 to 5 lobes of the nucleus, But in cases of megaloblastic anemia, the lobes of nucleus of neutrophil they increase more than 5. So these are called as hypersegmented neutrophils. So on peripheral film, there are macrocytes, ovelocytes, teardrop cells, deformed cells, hypersegmented neutrophils. Because DNA synthesis impacts or affects all the blood cells, therefore changes will be seen not only in the RBCs but also in the WBCs as well as in the platelets. Pancytopenia is another feature that is seen in megaloblastic anemia because of ineffective erythropoiesis and ineffective formation of the white blood cells as well as the platelets. The granulocytic precursor cells, they are also larger in size. The erythroid precursor cells are also large in size. And in the picture on the bottom, you can see a large megakaryocyte that is showing a multi-lobed nucleus. So all the precursor cells of RBCs, WBCs, and platelets, they are larger in size, abnormally large in size. On bone marrow examination, you can see in this picture how a normal bone marrow looks like. You can see mature cells and few nucleated cells also. While in case of megaloblastic marrow, the picture is hypercellular. There are more cells and there are abnormally large precursor cells, large erythroid precursors as well as large granulocytic precursor cells. Normally, a mature RBC does not have a nucleus. However, in cases of megaloblastic anemia, because immature cells they are also released in the peripheral circulation, therefore the RBCs present on peripheral smear also show a nucleus. Now, what is the role of vitamin B12 and folic acid? These two vitamins they are coenzymes required for the synthesis of DNA-based thymidine. And when there is deficiency of these vitamins or impairment in the metabolism of these vitamins, it results in inadequate synthesis of DNA, which results in defective nuclear maturation. So that is why we see abnormally large cells in these cases. Vitamin B12 is a complex organometallic compound which is also known as cobalamin. It is water soluble, and humans they are totally dependent on the dietary vitamin B12 because the microorganisms that form this vitamin they are present in the gut or the intestine of animals. So the humans when they eat food from animal source they get this vitamin. These are the foods that are rich in vitamin B12. These include fish, crab, cheese, chicken, eggs, red meat, milk, and some of the plants they also have some amount of vitamin B12 like almonds. There are four chemical forms of vitamin B12: cyanocobalamin, hydroxocobalamin, adenosylcobalamin, and methylcobalamin. Adenosylcobalamin and methylcobalamin are the functionally active forms. The functions of vitamin B12 include keeping our brain and nervous system healthy, helping in the formation of red blood cells, helping in the formation of genetic material, both DNA and RNA, and helping in balancing the levels of homocysteine in the blood. When homocysteine becomes increased in the blood, it can lead to atherosclerosis and myocardial infarction. In the picture on the bottom, you can see that vitamin B12 is also involved in the formation of tetrahydrofolate. So when vitamin B12 it converts homocysteine into methionine, it also simultaneously is converting or helping in the conversion of methyl tetrahydrofolate to tetrahydrofolate, which is folic acid. So both of these are linked with each other. Regarding the metabolism of vitamin B12, when it is consumed in the diet, it is attached to heptacorin, which comes from the salivary glands. B12 and heptacorin, they travel in the intestine, and then when they travel in the intestine, the absorption occurs in the distal ileum. B12 and heptacorin, they travel in the intestine, and when they are traveling in the intestine, the pancreatic enzymes, they digest these two, and heptacorin is separated from B12. An intrinsic factor which comes from the parietal cells of stomach, it attaches to the B12. Now B12 and intrinsic factor, when they combine, they are absorbed by the cells of the distal ileum, and distal ileum is the place where the absorption of vitamin B12 occurs. So when this is absorbed, it goes to the portal circulation, and through the portal circulation, it is taken up by the liver and stored into the liver. The excess is excreted by the kidneys. This is another picture that is showing the metabolism of vitamin B12. You can see B12 first binds to heptacorin from salivary glands, then it travels into the intestine. In the intestine, the pancreatic enzymes, the proteases, they separate the B12 from heptacorin, and intrinsic factor, which comes from parietal cells of the stomach, it attaches to the B12, and then this is absorbed by the distal ileal cells. And when B12 goes into the blood, transcobalamin uh, goes into the blood. Transcobalamin helps to transport it, and finally B12 goes into the liver where it is stored, and then it is released to the rapidly proliferating cells in the bone marrow and the gastrointestinal tract. The causes of vitamin B12 deficiency include inadequate intake, like in cases of alcoholism or vegetarian diet, some diseases of the intestine, like Crohn's disease, bacterial overgrowth, and ileal resection, then malabsorption, which can be because of some food, can be due to lack of intrinsic factor or lack of parietal cells. Defective transport, like in cases of transcobalamin deficiency, in cases of gastrectomy, because intrinsic factor comes from the stomach. So in gastrectomy, intrinsic factor will be lost, so vitamin B12 cannot be absorbed. Tapeworm infestations can also result in vitamin B12 deficiency, and then there are certain drugs and chemicals that can result in vitamin B12 deficiency. Possible signs and symptoms of vitamin B12 deficiency include palpitations, pallor, shortness of breath, muscle weakness, fatigue, irritability, tingling, constipation or diarrhea, a red, beefy tongue, nausea, vomiting, loss of appetite, vision loss, weight loss, and disorientation. Pernicious anemia. This is a type of megaloblastic anemia, and it is an autoimmune disorder. This is a type of megaloblastic anemia. It is an autoimmune disorder in which, because the immune system, it destroys the intrinsic factor. Therefore, vitamin B12 is not able to absorb, and this results in deficiency of vitamin B12. Now, the immune system may either be active against the parietal cells that are forming the intrinsic factor, or they may form antibodies directly against the intrinsic factor, thereby resulting in deficiency of intrinsic factor, which is necessary for the absorption of vitamin B12. Now, pernicious anemia, it occurs in all racial groups, especially Scandinavians and Caucasians, they are affected. Older adults are more affected. There is genetic predisposition for this disorder, and it is also associated with other autoimmune conditions. like autoimmune thyroiditis. It may be associated with achlorhydria, anti-intrinsic factor and anti-parietal cell antibodies, and increased incidence of gastric carcinoma. Regarding the pathogenesis of pernicious anemia, because there is an autoimmune reaction, there is activation of CD4 T cells, which result in damage to the gastric mucosa. The mucosa becomes atrophied. There is decreased secretion of intrinsic factor. Because intrinsic factor is deficient, binding of B12 with intrinsic factor does not occur. Binding of B12 and intrinsic factor complex may be stopped by another antibody, which can occur in this case, and this leads to pernicious anemia. So, in pernicious anemia, either there may be decreased secretion of intrinsic factor, which is caused by type 1 antibody, or there may be another antibody, type 2 antibody, which may block the binding of vitamin B12 and intrinsic factor complex to the mucosal receptor. So, various antibodies, autoantibodies may be formed against the intrinsic factor or the vitamin B12 and intrinsic factor complex. There are three types of autoantibodies that occur commonly in pernicious anemia. These are type 1 antibodies, which block the binding of B12 to intrinsic factor. Type 2 antibodies prevent binding of intrinsic factor and vitamin B12 complex to the ileal receptor. So, although intrinsic factor will be formed in this condition, but the complex will not be absorbed by the ileum. The type 3 antibodies, they recognize the gastric proton pump, which is present in the gastric parietal cells. The lab findings in pernicious anemia show pancytopenia. Pancytopenia is because of vitamin B12 deficiency, DNA synthesis is impaired, and DNA synthesis is required for the formation of all three cells, RBCs, WBCs, and platelets. So, all three cell lines are affected, and therefore, there is pancytopenia, there is megaloblastic anemia, the cells will be abnormally large in size. Anti intrinsic factor and anti parietal cell antibodies may also be seen in this case. So here in the picture, you can see a hypersegmented neutrophil and macrocytic RBCs. The bone marrow will be hypercellular and megaloblastic. Other features regarding the morphology of pernicious anemia include diffuse chronic gastritis, because autoantibodies are formed against the gastric mucosal cells and they lead to inflammation. There is fundic gland atrophy. Glandular epithelium is replaced by the mucus secreting goblet cells, which is called as intestinal metaplasia, and the mucosal cells, they also show megaloblastic features. The tongue becomes shiny, glazed, and beefy. This is called as atrophic glossitis. This is another feature of pernicious anemia. Now, because vitamin B12 is also required for the healthy functioning of CNS and brain, therefore, when there is pernicious anemia and deficiency of vitamin B12, this results in demyelination of the spinal tracts. Axons are lost in the spinal cord. There is weakness, there is abnormal sensation, and there is tingling in the limbs because of vitamin B12 deficiency. Now, Schilling test is this was previously used to find out the cause of vitamin B12 deficiency. This is no longer used because now we have more advanced type of tests, serological tests that help us to assess the cause of vitamin B12 deficiency. So, in Schilling test, radio-labeled vitamin B12 is first given orally, and then this is followed by an intramuscular dose of unlabeled vitamin B12 after an hour. So if the absorption is normal, this means that vitamin B12 deficiency may be due to dietary deprivation or because of strict vegetarian diet. If the absorption of vitamin B12 is impaired, this shows that either it is pernicious anemia or there may be some other causes. Then, to check whether it is because of pernicious anemia or because of other causes, intrinsic factor can be given orally if the deficiency is corrected. This means that it was due to pernicious anemia, and if deficiency is still not corrected by giving intrinsic factor, this means that there may be other causes, uh, like intestinal malabsorption or tapeworm infestation or some drugs or chemicals that may be interfering with the absorption of vitamin B12. So how will we check for normal absorption and impaired absorption? If the absorption is if the B12 is absorbed within the blood, it will be excreted through the kidneys. If the absorption of vitamin B12 is impaired, it will not be absorbed in the blood and it will come out into the stool. Clinical features of pernicious anemia include a slow onset. This is a progressive disorder. So pernicious anemia has a slow progressive onset. There is moderate to severe megaloblastic anemia. There is deficiency of white cells along with hypersegmented neutrophils. The serum vitamin B12 is low. The serum levels of homocysteine and methylmalonic acid, they are elevated, and they are elevated because vitamin B12 is necessary for the metabolism of these compounds. Serum antibodies to intrinsic factor may be present, which will indicate that this is because of pernicious anemia. Other clinical features of pernicious anemia are atrophy and metaplasia of gastric mucosa. This increases the risk of gastric cancer, and elevated homocysteine levels increase the risk of atherosclerosis, thrombosis, and myocardial infarction. Vitamin B12 deficiency may be treated by giving B12 fortified food, or it can be corrected by giving vitamin B12 supplements orally or by injection. Folic acid deficiency is another cause of megaloblastic anemia. Humans are entirely dependent on dietary sources for folic acid. The folic acid that is present in the diet, it has folyl polyglutamates. Polyglutamates, they are sensitive to heat. So when we are cooking food or frying food or steaming food, folic acid that is in the form of polyglutamates, it is destroyed. Folic acid, it is necessary for the formation of red blood cells and for the formation of neural tube during embryogenesis. These are the foods that are rich in folic acid. Regarding the absorption of folic acid, polyglutamates in diet, they are taken through the diet, and then in the intestine they are broken down into monoglutamate. They are absorbed in the proximal duodenum, and then when they enter the blood circulation, they are converted to tetrahydrofolate. Now, tetrahydrofolate, it circulates by binding loosely to albumin, and it can also circulate by binding to folate binding protein. And it is circulated to those sites where it is required for the formation of RBCs, like in the bone marrow, and for the formation of neural tube. Folic acid is needed for DNA synthesis, for normal maturation of red blood cells, white blood cells, and for the synthesis of DNA bases. Causes of folic acid deficiency include reduced intake, reduced absorption, increased demand, and various drugs. Signs and symptoms of folate deficiency include gray hair, anemia, fatigue, weight loss, birth defects, swelling of tongue, depression, and mouth sores. Deficiency of folic acid causes megaloblastic anemia. All the metabolic processes that are dependent on tetrahydrofolate, they are reduced, like the synthesis of purines, pyrimidines, conversion of homocysteine to methionine, and the synthesis of deoxythymidylate monophosphate. So DNA synthesis is impaired. For the diagnosis of folate deficiency, we check for the folate levels in the serum or red cells. Checking the folate levels in red cells is more specific. Serum homocysteine levels are increased, but methyl malonic acid concentrations are normal in cases of folic acid deficiency. In cases of vitamin B12 deficiency, both homocysteine as well as methyl malonic acid are increased. Neurologic changes do not occur in folate deficiency as they occur in vitamin B12 deficiency. So folate deficiency will again show a picture of megaloblastic anemia. Now, anemia that occurs because of vitamin B12 deficiency improves with the administration of folic acid because folic acid has a masking effect. It corrects the anemia that is occurring because of vitamin B12 deficiency, but it cannot correct the neurological symptoms or the neurological defects that are occurring because of vitamin B12 deficiency. So those symptoms, they might be further aggravated if folic acid is given in cases of vitamin B12 deficiency. So it is very important to correct the exact cause of megaloblastic anemia. Coming to anemia of chronic inflammation, impaired red cell production can be associated with chronic diseases because there is systemic inflammation, and in systemic inflammation, various cytokines are produced that impair the production of red cells. This is a common cause of anemia in hospitalized patients. There is reduction not only in the proliferation of erythroid progenitors, but also iron utilization is impaired. Anemia of chronic inflammation is divided into three types: chronic microbial infections, chronic immune disorders, and tumors. In anemia of chronic inflammation, there is abundant stored iron within the tissue macrophages. Interleukin 6, that is produced during systemic inflammation, increases the hepatic production of hepcidin. Hepcidin inhibits ferroportin in macrophages, and therefore iron is not transferred from the storage pool to the erythroid precursors. So although there is a lot of iron in the body, stored in the form of stored in the macrophages, but it is the body is unable to utilize it. So the erythroid precursors, they become starved for iron. Also, the inflammatory cytokines, they suppress the production of erythropoietin. So the progenitor cells or the precursor cells, they do not proliferate properly in the bone marrow. Here you can see in the picture, there are two mechanisms by which chronic inflammation leads to anemia. Cytokines are produced. These cytokines not only impair the release or synthesis of erythropoietin, but they also cause hemolysis. They also lead to increased levels of hepcidin. Hepcidin, when it is increased, it does not allow the stored iron from the macrophages to be released so that the bone marrow can utilize it. So there is decreased proliferation of erythroid progenitor cells, resulting in impaired erythropoiesis. Laboratory findings will show mild anemia, which may be normocytic and normochromic or hypochromic and microcytic. Dominant symptoms will be those of the underlying disease. The bone marrow macrophages will show increased iron. This can be visualized on bone marrow biopsies by using special stains. Serum iron levels are going to be low in anemia of chronic disease. Serum ferritin level will be high because the stored iron is higher in the body. The total iron binding capacity is reduced. This rules out iron deficiency as the cause of anemia because in iron deficiency anemia, the total iron binding capacity is increased. Now, there are three other conditions in which anemia occurs. In renal failure, the cause of anemia is the reduced synthesis of erythropoietin. Erythropoietin is necessary for erythropoiesis. Therefore, when erythropoietin is deficient, it results in anemia. In liver disease, what happens is that the stores of vitamin B12 and folic acid they are reduced, and this leads to anemia. Also, liver disease can result in the production of various cytokines, which will result in decreased release of erythropoietin, and ultimately this will reduce erythropoiesis. In cases of certain endocrine diseases, like in hypothyroidism, anemia can occur. And this will be normocytic and normochromic. This is all. Thank you.